Good afternoon, everyone. Good afternoon, everyone. I'd like you, as you're taking your seats, to welcome you to session number 3 today. If I can ask everyone to quickly take their seats so we can get started this afternoon. I imagine there'll be a few people trickling in from lunch, but I wanted to get started. So I want to extend a welcome to all participants, both attending both in person and virtually, back to the afternoon session of the forum. I hope you had an absolutely delightful lunch break and had the opportunity to connect with colleagues, whether they be current colleagues or new colleagues. One of the benefits of having the Western Immunization Forum is we get to meet individuals who are as passionate about immunizations and public health as we all are in BC, so this is fantastic. And I want to extend a great big thank you to the organizing committee for setting up this day and for the wonderful lunch that we have. All the names of the organizing committee and the administrative support are listed on the back of your program, so I just ask for a warm round of applause for all the hard work. Great, so this is an exciting afternoon session. So the first plenary of this afternoon is immunizations in special populations. So we have 2 speakers this afternoon. We have Dr. Catherine Burton from Alberta, and we also have Charlene Rattlesnake from Alberta as well. I'll just remind everybody that there's a combined question and answer period at the end of the plenary presentations, and just a reminder too that I encourage you to use Slido to submit your questions, and the QR code for Slido is in your program. So I'd like to welcome our first speaker. So Dr. Catherine Burton is an Associate Professor of Pediatrics at the University of Alberta, and Catherine will be speaking about the personalization of immunization recommendations for immunocompromised children. So Catherine, and Catherine's specialty is and expertise is in pediatric infectious diseases. So Catherine, please welcome to the stage.
Hi. Thank you very much for the introduction, and thank you for the opportunity to come and speak with you today. Make sure I know how this works. Will this change the slide? Okay, perfect. So we're changing topics a little bit here after lunch, which is nice, a little bit of a nice break and a fresh take with a different topic here. And I'll start just with disclosures. I'm very fortunate to have funding from the agencies listed here, and also I will be discussing off-label use of live varicella vaccine as well as measles, mumps, and rubella vaccines in the talk today. So I hope that at the end of this talk that everyone will be able to appreciate some of the general principles of immunizations in immune-compromised populations, also to be able to describe some of the relatively new research and clinical guidance that actually supports the use of certain live viral vaccines in pediatric solid organ transplant recipients. And then I want people to be able to discuss or at least reflect upon the importance of individualizing vaccine recommendations for immunocompromised individuals. So why are we even talking about this? I suspect that everybody in the audience probably knows the answer to this, but there is considerable morbidity and even mortality from common vaccine-preventable diseases in immune-compromised populations, things like pneumococcal disease, influenza, and then, unfortunately, outbreaks of less common vaccine-preventable diseases continue to occur. Sorry, I'm realizing these are not actually the most updated slides, but we'll go with it. Okay, so we will start just by talking generally about some of the principles of immunization in immune-compromised hosts. So the goal of the immunization programs for immune-compromised hosts would be to maximize benefit and minimize harm. Now, this principle is, of course, not specific to immune-compromised individuals, but I wanted to take a minute just to talk about a few of the things that I consider specifically when I'm thinking about these populations. So when we think about maximizing immunizing benefit, we think about our vaccine choices. So beyond the routine vaccines that may be recommended, there may be additional vaccines that are recommended based on the specific immune-compromising condition or other medical conditions that these individuals may have. So they may actually be eligible for additional vaccines. The timing of immunization is very important in immune-compromised populations, and we really want to make sure that we're immunizing when we would expect there to be the most benefit from the vaccines and when the vaccines would be the safest, and we're going to talk about that a little bit more in a minute. We also need to consider things like the optimal dose of the vaccine, the number of doses, as well as the dosing intervals, because many immune-compromised people may not have as robust or as long-lasting a response to some of our vaccines. So we may make changes in terms of using higher doses of vaccine, like the hepatitis B vaccine, or using more doses of vaccine, like the HPV vaccine, or changing our vaccine intervals if we're doing things like trying to optimize vaccination prior to the onset of immune suppression. We may use accelerated immunization schedules using minimum intervals for vaccines, which may be different than what we would do in the routine population. If we look at minimizing harm, one of the things that I just want to focus on with this population is really the caution with live vaccines, and we'll come back to talk about that a fair bit in my presentation today. Okay, so immunizing when the best response is anticipated. So what does this mean? Generally, if we're immunizing individuals that are immune compromised or have other chronic health conditions, we want to immunize early in the disease course when they would be thought to have the best response to the vaccines. And ideally, we would like to have immunizations optimized prior to any immune suppression actually being started. So for instance, if you have a patient that's going to be starting a new medication that's immune suppressing or is going to be having a solid organ transplant or a stem cell transplant, well, stem cell transplant's a bit of a different situation, but a solid organ transplant, you'd ideally like to optimize their immunizations prior to the onset of that immune suppression when they're likely to have a better response to vaccines, and also when it's safer to give some of the vaccines like live vaccines. If that's not possible, then we ideally try to immunize at the point of the lowest immune suppression. Another thing that we often are considering in these populations who are sometimes more complex is administration of the parenteral live vaccines, measles, mumps, rubella, and varicella, remote from administration of any blood products. And we'll talk a little bit more about that as we go through the presentation. One thing I can't talk about immunization in immune-compromised individuals without mentioning that we always need to really actively consider the individual's environment. I talk about this with my patients as being the circle of protection, and I think it's a missed opportunity if we don't always think about that and really actively try to encourage the immunization of household members and contacts and caregivers for these immune-compromised individuals. You know, I frequently, if I'm assessing a child who's immune-compromised for their immunizations, I will suggest to them that the family members or the caregivers make an appointment at the same time and have their immunizations reviewed to see if they're up to date, to see if they can be optimized, all with the idea of really creating this circle of protection for these more vulnerable individuals. I didn't actually want that one in there anymore, so we're just going to skip over that. So going on to the minimizing harm. So I think it's important for everyone involved with immunization to recognize that we do have to be cautious with live vaccines in immune-compromised individuals. And generally, if there is significant immune compromise or if a degree of immune compromise really isn't known, then the safest thing to do is to hold off on live vaccines for that moment in time. Now, that doesn't mean that that individual can never get that live vaccine, but you're always best to get that information so that that vaccine is given in safely. And there are many ways that we can go about figuring those things out and actually being able to give live vaccines to a lot of these individuals. If we are trying to give live vaccines prior to the onset of immune suppression, which is always the goal if we have a choice, we like to administer them at least 4 weeks prior to the onset of immune suppression. And this number is a lot of places, but I find that it's not often actually explained why this is, right? So the reason for this is that there's the concern that there may still actually be circulating virus after getting these live vaccines. And if you were to then institute significant immune suppression soon after getting the vaccine, vaccine, then there would potentially be a risk of disease, which is obviously something that we're looking to avoid. Now, as I mentioned, live vaccines can be safely given to many immunocompromised individuals, so there often may be clinical or lab criteria that can help to determine whether it's safe for individuals to get live vaccines or not. And sometimes we do have to consult with other experts in things like infectious diseases or immunology to do more in-depth evaluations and looking really at the risks and benefits in these situations. Okay. So immunizations in immune-compromised individuals, it's complex. Really, as for everything related to public health and immunization, open communication with all of the members involved in this process is really key. And I would argue that everyone has a role in this, and those roles may be different. So they may be the role of, assessing immunization status early in the course of disease, or determining whether there are other underlying medical conditions that may make somebody eligible for other vaccines. They may be advocating for patients to receive vaccines while they're hospitalized for their condition, or when they're coming to the clinic when the opportunity arises. It might be encouraging them or family members to go and have their vaccination status kind of assessed and updated. And as I said, there are always those other people that can be engaged that can help in some of the more complicated decisions. So, well, this looks a little different, but that's okay. Speaking of kind of some of the experts, I want to talk a little bit about the Special Immunization Clinic Network that I am fortunate to have been able to be involved with since quite close to the beginning of my career. So this is a really unique Canadian, I didn't touch anything. Switch my slide again? Can I go back? Oh, maybe. Oh, okay. Oh, great. Okay. All right. So, Special Immunization Clinic Network. So this is a really unique network in Canada that involves infectious diseases physicians, immunologists, and allergists. And really the goal of this network is to support public health and other healthcare providers involved in immunization in managing children and adults now that have had challenging adverse events following immunizations, or that may have other underlying conditions that may affect the safety or the efficacy of the vaccines that are being used, such as immune-compromised individuals. So the Special Immunization Clinic Network is led by Dr. Karina Top, who is out of the University of Alberta as well. There are 13 special immunization sites across Canada. It started out as only pediatric sites, and then throughout the COVID-19 pandemic, multiple adult sites were added, and the network is hoping to expand its adult sites and also pediatric sites to other parts of Canada that are currently underserved, including the Canadian North. So the SIC network is a clinical network, but in addition to being a clinical network, it also has served as a platform for multi-center research in adverse events following immunization, but also in looking at the safety and immunogenicity of certain vaccines in immune-compromised populations. And I'm going to talk about some of the work that the SIC has been involved with related to that. Okay, I'll just keep talking. Okay, so I was going to show you a picture that had some clips of some of the more recent research that has actually been going on related to the use of live varicella vaccine in pediatric solid organ transplant recipients. Okay, so in the past, certainly in all of my teaching and learning, one of the key messages that has always been, loud and clear is that children or adults who have had solid organ transplants absolutely should never receive live vaccines because it's dangerous. It's not safe for them. And so this is something that, anybody that's been involved in the care of transplant patients, and certainly patients and families, would have been strongly educated around prior to their transplants. But in the last last number of years, there has been a lot of research involved in this area and looking to see whether it is actually safe and actually useful to start to use the live varicella vaccine in select children who have had solid organ transplants. So why is this topic of interest? Well, there's the slide with some of the research that's gone on in this area. Okay, perfect. So why is this of interest? There is a significant risk of more severe and more complicated varicella disease in pediatric solid organ transplant patients, and also varicella exposures are commonly quite a source of stress for families and patients that have had solid organ transplants. So if they are exposed, if there's a child at school that has varicella and there's this exposure, can be a very stressful experience. And there's also a significant burden if that person needs to come in for post-exposure prophylaxis after a varicella exposure in terms of getting varicella immune globulin and perhaps antivirals and that kind of thing, right? So you might ask, well, why didn't we just immunize them before transplant? Because that's what I just told you we should be doing in all of these situations. And we try, we really do, but it can be really challenging to do. And it's challenging for a number of reasons. One of the biggest reasons being that many children that require transplant, especially a liver or heart transplant, often need a transplant at a very young age, so at less than 12 months of age when these vaccines would routinely be given, right? So we try to get around that a little bit by actually giving the vaccines earlier in our accelerated schedules for these populations. So we start using these vaccines actually at 6 months of age rather than the 12 months. So if we have a patient where we have some time before transplant, even if they're younger, we can often get at least one dose of these varicella and measles, mumps, rubella vaccine in before transplant. But often there's significant urgency to transplant. And we just talked about the fact that after getting a live vaccine, you really don't want to institute this immune suppression for 4 weeks afterwards, right? So that means that if a child gets these live vaccines prior to transplant, they get put on hold for their transplant for 4 weeks. So what does that mean? That means that they're potentially missing out on an opportunity to receive a life-saving organ for 4 weeks, right? So sometimes we have that luxury, but a lot of times we don't have that luxury, so it's difficult. There are other little things too. Sometimes kids are immune suppressed prior to the transplant, depending on the reason they need it. They may be having a transplant for a malignancy or something like that. So there are a lot of reasons why, despite our best efforts, it's difficult to actually have these children optimally immunized prior to transplant. And as I mentioned, historically, the use of live varicella vaccine has been contraindicated after transplant. So if they didn't get the vaccine before transplant, then they were left to live the rest of their lives constantly being worried about potentially being exposed to varicella and having to run into the hospital perhaps to get post-exposure prophylaxis. So given all of this and all of these challenges, the transplant community really started to question, can these live vaccines actually be given safely after transplant? There had been some research that had been ongoing in this area. And in 2018, I was fortunate enough to be invited to participate in a consortium that involved many experts from across the world, actually, in infectious diseases, in immunology, transplant specialists, as well as pharmacists and other vaccine providers. And at this consortium, we reviewed all of the data that existed at the time regarding the use of live vaccines in solid organ transplant recipients, and actually came up with some guidance around how these vaccines could actually be used in these populations. So I just want to take a couple of minutes to really hit the highlights of what the data showed. So the takeaway is that really the data supports the safety and immunogenicity of the use of live varicella vaccine in pediatric solid organ transplant patients. So over 700 solid organ transplant patients, the majority of whom were pediatric, the majority had had a kidney or a liver transplant, had received the varicella vaccine. And overall, about 80% of them had a seroconversion to a positive varicella IgG after getting the vaccine, with a higher seroconversion in the studies where at least 2 doses of vaccine were given. So it looks like it works, but the big question on everybody's mind is the safety of it. So overall, there was a really reassuring safety profile, actually. So rash was not uncommon, and if you look at all the studies together, about 10% of kids develop some kind of a rash after getting the vaccine, which is higher than we would expect generally in kids, but these were not all rashes that were likely varicella. So there were only 13 out of 635, or about 2% in these studies that actually had suspected vaccine strain varicella after the vaccine, and of those, only 2 of them were actually proven to be that. And most importantly, all of these 13 children recovered fully with no complications. Many of them did receive antiviral medications against varicella, but all went on to full recovery. Another really important thing that came out of these studies was that there was no signal for increased organ rejection, which was certainly a concern initially in the transplant community. So that was also very reassuring. So based on this data, at the consortium, we came up with this kind of guidelines, this guidance using a very cautious stoplight approach, okay? So at the time when these came out, really children that had solid organ transplant were grouped into these 3 categories. So there was the red light category for kids in whom at that time it was suggested to defer use of live vaccines after transplant. So these would be children that were on very high level immune suppression, and also children that had received lung or multivisceral transplants, and at the time heart transplants, although since then there's been some new data in that field. Then there was the yellow light category, and these were patients that didn't quite fit exactly the criteria that had been used in the studies. So it was a little bit less clear whether or not the live vaccines could be safely used in this population. And generally, these were kids where it was recommended that they get a little bit more immune investigation before determining whether they would be eligible for vaccine or not. And then there was the green light category, and these were the ones in whom it was deemed likely safe to use the live vaccines after solid organ transplant. So the Special Immunization Clinic Network really thought that optimizing varicella immunization in pediatric solid organ transplant patients was a very, very important area to focus on. And with this in mind, the network helped to facilitate the development of clinical protocols at multiple children's hospitals across Canada, as well as developed a mixed methods study looking at a couple of different things. So the first thing that they actually looked at using qualitative methods was a study to identify barriers and facilitators to implementation of these clinical protocols. So why did we actually think that was important? Well, as I said before, this represented a major paradigm shift in immunization, right? So this wasn't just something that was going to be a quick update and all of a sudden everybody was going to be on board. This is a major change, and we recognized that we needed to understand where everybody was coming from if we wanted to be successful at all in making this change. So I think that was a really important thing to do. And then the second part of the study was to evaluate the safety and immunogenicity of the live varicella vaccine given according to these protocols that had been developed. So I'll just give you an example of the clinical protocol that we developed at the Stollery Hospital in Edmonton where I work. So we looked at kids that were at least a year post-transplant from a heart or liver transplant, were doing well clinically, had a negative varicella IgG, had had less than 2 doses of varicella vaccine pre-transplant, were on what we considered to be minimal immune suppression. We did have criteria for that, had normal basic immune investigations for age, and really importantly, were able to reliably follow up for any potential adverse events after immunization. We did significant education around monitoring for adverse events following immunizations with the families as well as with the teams, and we also had active follow-up with telephone follow-ups from our team between 3 and 4 weeks after vaccination. So this is something that I'm very, very proud of in this work. So we worked with public health in Alberta to actually have the immunization guidance for children who have had or going to be having solid organ transplants updated, so it actually reflects that carefully selected pediatric renal and liver transplant recipients can safely receive the varicella vaccine. So we really strongly believed that if we were going to make this change, it had to be integrated into the way that our vaccines were delivered in Alberta, so that it would be sustainable and it would be accepted by the population. So we were able to do this actually quite early on in the course of this, and so all of the children that we assessed got their varicella immunization through the public health program, just as they normally would after they had a letter stating that they kind of met the eligibility criteria. So I just want to talk a little bit about the qualitative study that was a part of this. So through the use of interviews, essentially we investigated, or we learned more, I should say, about the views and experiences that both healthcare providers and patient families had regarding the use of live and non-live vaccines before and after solid organ transplant. And we specifically sought to identify barriers and potential facilitators to implementing this guidance for the use of live varicella vaccine after solid organ transplant. So I just want to go over 3 things that we felt were really key insights that came out of this study that are related to communicating changing recommendations. Now, there has been a lot already discussed today and in some of the posters and that kind of thing that I think this is very much in line with, but I think that these were important findings that came out of the study. So the first thing here is that healthcare providers really need to understand and communicate to families how and why guidelines and recommendations change over time. I think that we probably all experienced this during the COVID-19 pandemic, right? That the guidance that we're offering at the time is based on the knowledge that we have at the time, and it should be almost expected, actually, that may change over time, because that's what we're meant to do. We're meant to update things. We're meant to improve on things over time, right? So these things aren't static, and I think that that's a very important thing to communicate. The second one is not surprising. I think everyone knows here, obviously, that trust between healthcare providers and families facilitates communication. What really came out in this study was that the parents were very, very trusting of their transplant teams. They had been through a journey together, and it really seemed like the transplant teams were in the ideal situation to be the ones to communicate this significant change to their family. But in order to do that, the transplant teams need to have the knowledge and they need to have the support to be able to actually do that. And then the third thing that came out was that information about new guidelines and evidence really needs to be communicated in a child and family specific manner that resonates with parents and families' roles as leaders. So these families have been going through their transplant journey. They've been working on the assumption that their child would never be able to receive varicella vaccine. They would always be vulnerable to that, right? And they develop strategies to try to protect their kids and their families without using vaccine, because that was never an option for them, right? So we need to make sure that when we're communicating these changes, that they fit in with these strategies that have already been developed, or at least complement them, and that we're not completely asking them to change their whole approach that has been working for them to protect their children over a number of years. Okay, just a quick update about the last part of the study, which is evaluating the safety and immunogenicity of the live varicella vaccine given according to these clinical protocols. So almost 60 Canadian pediatric solid organ transplant recipients have been vaccinated with the live varicella vaccine. And unfortunately, I don't have the data to present to you yet. The analysis is ongoing. But I will share a little bit of learning along the way, which was maybe not a complete surprise to us. Not a lot of the patients, many of the patients did not fit into the nice, clean, green light category. Many of them fit in that yellow light category. And so going forward, I think that we need to adapt the clinical kind of guidance so that there's more guidance in terms of what to do in those situations so that we can help to facilitate immunization of those children. So what is the potential impact of this? Well, we're really hoping that this information will help to inform implementation of protocols for the use of live varicella vaccine in pediatric solid organ transplant recipients more broadly across Canada, and we are developing educational materials for multiple different groups that are involved in this to support that implementation. Okay, I'm going to take my last couple of minutes to just talk a little bit about the importance of individualizing vaccine recommendations for immune-compromised individuals. So we talked about the fact that this is complex for a lot of reasons, right? And I am a very, very strong believer and very grateful that we have phenomenal protocols and schedules for immunizations in immune-compromised individuals. That certainly is a benefit, but we also need to have the flexibility to sometimes individualize those recommendations, right? So we need to balance the risks of avoiding or delaying vaccines because of safety or efficacy concerns in immune-compromised individuals with the risks of susceptibility to vaccine-preventable diseases. So I just want to talk about a quick case scenario. So this is an 8-year-old boy who had a liver transplant 7 years ago when he was 7 months of age, wasn't able to receive varicella or MMR vaccines before transplant because of his young age and urgency of transplant. He was determined to be eligible to receive live varicella vaccine, went on to receive 2 doses of varicella vaccine and to have a positive varicella IgG after the 2nd dose of vaccine, didn't have any adverse events after immunization. Now his family is planning with him to take a long trip to India, to an area where there is measles transmission occurring, and they wonder whether their son would be able to get MMR vaccine. So in this consensus statement from 2018, while we did look at the data looking at MMR vaccines, it was recommended that in low incidence areas like Canada, hopefully continues to be, for measles, these slides had to be submitted 4 weeks ago, so that we would restrict the use of MMR vaccination after transplant to local outbreaks or planned travel to high incidence areas. So it was different than the recommendation for varicella. That was for a couple of reasons. One, because of the potential risk of being exposed, but also because for varicella, we have an antiviral medication that works very well against it, which is not the case for measles, for instance. So since then, though, there has been a large study done in the US involving children from 18 different centers, the majority of whom were liver transplant recipients, and over 200 pediatric solid organ transplant recipients received MMR vaccine, mostly according to the guidelines that were presented in the consensus document. And 86% of them developed protective measles antibodies, and there were no serious adverse effects, no cases of measles or rubella. There was one potential clinical case of mumps, but it was never even confirmed, and the person recovered without any adverse effects. It's red, it's telling me to stop. I will stop in just a minute. So, sorry, how do I go back there? Oh, anyhow, so in that situation, you may consider, if you look at the risks and the benefits, that perhaps it actually would be beneficial to administer the MMR if there's reasonable data and balance with the risk of this person traveling to an area where there's significant measles transmission. This isn't something that we have been routinely recommending, but we are in discussions of this in the special immunization clinic. But we certainly, prior to making these changes, would again do the same that we did with varicella vaccine and engage our public health colleagues and our transplant colleagues so that if we do make these changes, everybody is on board with those changes. I guess I will skip over the last case for thought here. And so as not to cut into anybody else's time. But I just want to say that I feel very grateful for having the opportunity to work with so many dedicated individuals that have really worked hard to try and advance immunization in immune-compromised individuals. And I feel very proud that we've been able to make some of these changes. And I think that it makes us see that we can change things that have been really strongly rooted in our education for a long period of time, and we can make these changes, and I think that that will help us in the future to realize that that's possible and to advocate for doing that going forward. So thank you for your attention.
Thank you again, Dr. Burton, for the very informative presentation. I know I took away the key message for me was how do we maximize the benefit and minimize those harms for those children already facing health challenges, while taking into consideration the environment and the families that are dealing with these and working with these children that are immunocompromised. So thank you very much again, and thank you for the patience with the technology. Okay, next speaker is Charlene Rattlesnake. Charlene is a family and cultural coordinator in an early years program within the four-nation area of Maskwacis in central Alberta. And I welcome Charlene to the stage.
Ani, wapigis ko kwentisini kas, kakina ke tamskat nawao. So my presentation is called The Cultural Considerations While Using a Wraparound Approach, Learning from the Maskwacis Early Years Program to Increase Immunization Uptake. I have lots of slides, so I'm just going to talk really fast. I have nothing to disclose, so I just need to know how to advance the slide. Just this? Perfect. Okay. All right, so I'm going to talk a little bit about the program history, the partners that were involved, the program activities, our approach, our immunization successes, and then at the end we'll have some discussion or some questions. So the program partners are the Paul Martin Family Initiative. It's a registered Canadian charity that helps to improve education, health, and overall well-being outcomes for First Nation people. Maskwacis Health Services is the local education service in Maskwacis. We serve about 17,000 people, and local education authority. So what is the early years? It's a home visiting and an early childhood program designed with the families in Maskwacis. It positively impacts children, families, and employs community members. It's the only one of its kind in Maskwacis, and it fills a necessary gap in the community. Rather than replacing services, it works to enhance them. So where we started, it launched as a pilot in 2018 just in Ermineskin Cree Nation. So my community has 4 nations, and it started with 3 visitors and a program manager. There was research involving the implementation of a prenatal to an early childhood intervention program in a First Nation community to meet community gaps. Family, community, and elders are heavily involved in the planning and evolution of the program. And the pilot was funded by Brain Canada, and it expanded and funded by Indigenous Services Canada. So this is the most recent group picture of our staff. At the launch, there was 4 program staff, 3 visitors, and 1 manager, and now we're up to 32, and we are serving 201 families. The program goals in the beginning were to support healthy pregnancies and maternal wellness, enhancing children's language development and overall school readiness, providing play-based learning opportunities for children, and enriching children's pride and identity in the culture, and strengthening parenting capacity and family well-being. As you can see, increasing immunization was not an initial goal of the program. The approach is aligning traditional knowledge with scientific research. Every child in Canada deserves the opportunity to reach their highest potential, working hand in hand with Indigenous communities. The program strengthens parents' engagement in the child's healthy development before birth and into their school years. So most Indigenous people believe that life starts right at the moment of conception, and that's where teaching should start as well, not after the baby is born. Brain Canada recognized that the 9 months before birth and early years of a child's life are the most critical in shaping the structures and functions of the brain. Also recognized the importance of high quality, culturally appropriate early childhood programming for Indigenous families. The program was developed based on traditional knowledge, community innovation, effective practices, and most current scientific evidence around early childhood development. The project aimed at demonstrating that it's possible to improve outcomes by implementing a prenatal to early childhood intervention for pregnant Indigenous women and children living in First Nations. The Brain Canada funded with two goals: piloting the intervention and research on the effectiveness of the intervention. And so far, we've had really good outcomes. So this is kind of what the program looks like. Once somebody enrolls in the program, they're assigned a home visitor. The home visitor usually aims to visit once a week. We work with a box of toolbox cards. And then there's another portion where it involves group gatherings where people come together. A lot of times people are really isolated, and the group gatherings are really beneficial for them. And then when people, after they turned 2 years of age, they didn't want to give up the program, so the preschool programming was created. An 8-week Get Ready for Preschool program was started. This is kind of the elements of the early years program. At the center, you can see that relationship building is the most important part of the program. With Indigenous people, relationship building is really extra important because of the effects of colonization. Infrastructure is really important too, because a lot of the barriers include like lack of transportation and isolation. And then our approach, we have research involved in it. It's sustainable. We call it a wraparound approach, and I'll talk a little bit about that a little bit later. And then the training and learning, we want lots of cultural knowledge. We have the toolbox cards that I'll talk about, and we also have a course called Understanding the Early Years program. So this is what a typical home visit might look like. The home visitor is using the cards to help with the parent with her parenting journey. During COVID, we were able to keep doing the visits by providing the families with iPads, downloading all of our resources, and then doing Zoom visits. So COVID didn't really interfere with our visiting that way. Group gatherings. We have a dad here sharing the gift of song. We have other gatherings such as sweats, drum making, moss bag making, ribbon skirt making, STI info, so many more gathering topics. But what we found was the ones that had anything to do with culture, those were by far the best attended. There was a real, and there still is, a real hunger for cultural knowledge, even among Indigenous people. Just a few pictures of our culture camp where we had really good attendance. We had presenters from both, mostly all locally, and then some outside visitors. But again, these were well attended because of the hunger for the culture that lots of people are needing. This is a picture of our preschool program component of the program. It's an 8-week program where people can come with their child. It's not like daycare or Head Start where you just drop off your kid. You have to be involved. You have to stay for the duration. And another part of the program is this Get Ready for Preschool bus that we had. Essentially, we bought a bus, we gutted it, we turned it into a mobile play center where we were able to bring programming to people that couldn't come to the center for that. Evaluation, you guys all know the importance of evaluation. I'm not going to talk too much about that. We do have our own impact data system that Martin family helped fund, and it's always being updated. And we also have an external advisory committee. and it's just nice having that support. Engaging fathers and male elders. The program invites all parents and caregivers to be involved. Every year, the program sees more fathers participating and engaging in their child's development while learning traditional roles in parenthood from male elders. Our resources. So that's just a picture of the resources, and I heard somebody talk a little bit about resources, the importance of them, and in our case, it has really helped to have our own resources. Like when a parent comes to our center and sees a picture of their grandma or whatever on the wall, and I hear them say, hey, that's your grandma or whatever, it really goes a long ways to increase their pride and helps in identity. It helps build connections to families. We have building blocks that have our language on them. All of our resources have local people embedded in them. In our Understanding the Early Years course, we have local elders, videos of them in the course somehow, and they're talking about different traditional teachings about parenting. And the nice thing about the course is it can be applied to any community. So I've been to places like Toronto, where they have their own Indigenous community downtown, and what they do is they just take out our elder video and replace it by their local teachings, and it's adaptable to any community. So this is the toolbox that we are talking about. There's 6 sections. The first one there is prenatal, pregnancy, and birth. Language matters, nurturing care, meaningful moments, family well-being, engaging environment. So there's about 162 cards, and with each visit, the parents and the visitor talk about whatever topic is for that day. They're really conversation starters. Sometimes also you have to be adaptable to what that family needs that particular day. You might not even do a card. You might be in the middle of a crisis and something else is more important. So we adapt to the needs of that particular family. And a lot of Indigenous communities are in crisis all the time, and they don't even know it. Sometimes it's just a normal part of their life, and you wonder why immunization isn't a priority sometimes, because they're just trying to survive, right? In the last year, we've had, for the first time, more deaths than births. So that just goes to show you what crisis people are living with day to day. So the next slide. So my role is the Family and Cultural Coordinator. In the beginning of the program, they tried to do things with an Indigenous focus. They tried to invite people to come to sharing circles. People were really hesitant to go because it meant that they probably would have to share something. So there was very low attendance. And then I came along, and my role is to connect the participants with the cultural resources. And the beauty of that, and the reason that I love my job so much, is that I get to learn along with them. And it's also good for the elders in the community, because a lot of them have never been given a chance to do any teaching. Through the history of colonization, they've had to keep quiet and not they didn't have opportunities to do the teaching that we welcome today. And I've had people come to the center, I ask them to do a certain topic, and then they've made comments like, oh, I've never had an opportunity to share this teaching. So I really like that it doesn't only benefit the little kids, it also benefits elders, to come out of their shell, to teach what they know, and just build stronger connections. So The early years program started in Maskwacis in 2018, and this is an outdated slide as well. This one shows how it has expanded into 20 individual First Nations and 6 different geographical areas, but as of today, it has expanded into 8 geographical areas and 40 different communities. So in a short period of time, we have really expanded the early years program. We have people coming as far as Arviat, Northwest Territories, Nunavut, and they come and look at our program, and we help them with our challenges so they can avoid it. And it's just really expanded into, it's across the nation now. So immunization in the early years. One of the toolbox cards you can see here, it's a conversation starter. We might pull it out and say, hey, like, how much do you know about immunization, or do you believe in it? Or having nurses, we have 2 nurses on staff, has benefits because we have access to the immunization program. We follow the, it's called CHIP in Alberta, and we're able to pull up the records right then and there. If the visitors need information, they come to me and say, can you phone this person and give them information on this or that? The toolbox cards help visitors start those conversations, and it's really helpful also for the nurses because they have connections that other people in the community might not. And I was just reminded earlier about how important it is to have connections to other healthcare workers. We have a pediatrician who comes to our community, and one day there was a baby who came to one of our programs that had a really bad case of cradle cap. And because I had a connection to the pediatrician, I was able to text her. I text her a picture. And normally if you phone the clinic, they'll say, oh, we don't have an opening for 3 weeks. Or the receptionist might say, we might not be able to, we don't take walk-ins, things like that. But because I had that connection to her, she's like, okay, I need to see this baby right away, bring them in right away. So she was able to do an intervention, and it was a really good outcome. So it's really important to have healthcare workers connected in any kind of program. So again, because these, I don't have the most up-to-date information because these slides were due in January. So the February was when we were able to get the 2023, but you can see the percentage of 2-year-olds with complete primary immunization was significantly higher in 2021. And so the green shows the general community. The blue shows the community members who participated in our program. And the same thing with the 2-year-olds in 2022. Depending on the age that you're looking at and the year and the vaccine, our program participants are up to 6 times more likely to have up-to-date immunization just because of our approach. Thank you. So somebody talked about the importance of building relationships. So this is the result of building relationships. Having good connections with healthcare providers, I said. Coming into relationships with, well, what can this family teach me attitude, instead of like always being the professional, always being the one who has the best information. So just like, instead of what do I need to teach? And then having that wraparound care. So to me, wraparound care means what else in the community can we access? What else, how else in this community can we help this family? So their priority might not be vaccines, like I said. Their priority might be, oh, I need to get to the band office to register my child. Oh, I need to order a birth certificate first before I can even register my child. I need to find housing. I need to find food first. So if you take the time to do that kind of support before, they're more likely to agree to book that immunization and more likely to attend that immunization. We also have child minding. A lot of our families have 4 or 5 children, and to bring one to immunization is out of the question. So some of our visitors will go as far as taking all 5 of the family, and then while the mom is immunizing one in the clinic, she might child mind the rest of those 3 children. We have transportation issues too. I don't know how many of you have ever worked in First Nations. Most First Nations do have a transportation program, but it's very limiting. It's just the person that has the appointment can go. Sometimes they won't even let partners go to, like say, a ultrasound appointment. Sometimes they won't bring the other 3 children, or you have to have a band number to access the service, things like that. Our program is a little bit more lenient. We will bring partners. We might bring that extra child. We might bring that person if they're not actually like a band member registered to that band. We realize that lots of people have partners that are outside of the band, and we'll even provide services for them. We also don't have traditional borders, like if you live outside of the nation, we can't come and visit you. We do expand the program where we visit the families in the outlying communities, because the reality in most First Nations is that not everybody has housing. We have sometimes 3 or 4 generations of people living in housing. So we know the importance of helping that person get into a house off the reserve, and then we'll also go to them and bring the services to them, just because we're not restricted by borders. So it's really important to support other programs in the community. We don't only bring them to our services. There might be like a National Child Health Day event that another program is providing. So we make sure that they're able to go there if that's where they want to go. We might take them to go and pick up their breastfeeding coupon, things like that. So I think this was supposed to go somewhere else, but it just shows that 1-year-olds in January of 2024, this is one of the current ones, I guess, is still more than the general community, and then the 2-year-olds, again, is more than the greater population. This one I'm just going to go past because I see in the program there's some Canadian information. So I think I talked a lot about this already. So visitors help families navigate services, providing not only a ride but wraparound support. We have given over 450 rides to different things like prenatal appointments, immunization, housing, income support, birth registration, band registration. And so the outcomes are that, especially for prenatal, they're getting increased access to healthcare providers. So they're seeing the doctor more often, or whoever their healthcare provider is. We're not replacing medical service, but we're enhancing them. And then even during our transportation, we can utilize that as an opportunity to do a visit. So I think I talked about most of this stuff already, so I'm just going to go to the next one. So some of our key findings have participants have formed trusting relationships with their visitors, and just a little bit more about the importance of building those relationships and how sometimes it takes a long time for Indigenous families to form that trust. I've had a story shared with me where a visitor attempted a home visit 5 times before they were actually invited inside. Like, they just decided, oh, hey, this person's not going anywhere, and she really does want to help me, so maybe it's safe for her to come inside. So just successes like that are always really nice to hear. Participants report the program is culturally safe. They're increasing access to the other services in the community, and it has a really good reputation in the community. Recently, there was a cost-benefit analysis finished, and it found that for every dollar spent in the program, $4 to $11 were gained or benefited to program participants. Okay, so the early years has received recognition for the positive rates of immunization for program participants. Results have been shared at the conferences at Ottawa, at the Canadian National Immunization Conference, and we were awarded an Award of Excellence last year for the work that we're doing. The early years program has served as an example to other First Nations, and like I said, we have lots of people coming to visit our community to see what they can learn from our program. So elders' guidance. We really rely on elders' guidance. We are guided by a cultural advisory committee. We meet about 4 times a year. We kind of update them on our programming and then ask them what they would like for us to do. We never go ahead and just dream up things on our own. An example is we have a cultural building that was built in our yard, and it was at the advice of those elders to say, you know what, you need to have like a ceremony at least 4 times a year, once a season. And then we asked them, well, can we build something that will help facilitate that? And they said, go ahead, yes, you can do that. So it's really important to have every age to kind of evaluate us. So we get the parents to evaluate, we also get the elders to evaluate, and it's not only coming from like the workers or anything like that. It's really coming from the community. And yeah, I just kind of really flew through that because I thought I was gonna run out of time. And yeah, so this is just a community service provider saying that the early years is kind of like that gap and that glue to all of the different community programs. There's so many little things that kind of just help that middle ground and pick up some of the limitations of the community-based programs leave off. And so, yeah, Indigenous communities have always had their own best practices. Service providers, institutions must recognize that we know what is best for our children, and families and Western practices are not the only way nor the right way. Guidance from community and elders gives them a sense of ownership, and they're essential. Yeah, so that's pretty much the end of my presentation, and thank you for listening.
Thank you so much. I'll ask Charlene and Dr. Burton to join me on stage for the question and answer period, so I'll invite you to have a seat. And while they're settling in, I just want to say thank you again to Charlene. I really appreciate hearing about how traditional knowledge and teachings, as well as the sharing of culture, are benefiting families in over 40 different communities in Canada and in 8 different geographic regions, especially in light of the other challenges that these communities are facing. And it really struck me is that you're experiencing in some communities more deaths than births. So to see that the immunization rate is upwards of 6 times more than the general community is is encouraging, and just want to say great work in the wraparound approach. Thank you. Okay, so we have time for some questions. So Michelle, I'll ask you, are there any questions on Slido for our two presenters today?
Lots of questions. I'll start with a question for Dr. Burton. The first one is from Dr. Naus. Are commercial varicella antibody assays sufficient for establishing immunity post-vaccine in immunocompromised children, or do you recommend GP ELISA, or glycoprotein enzyme-linked immunoassay?
Is that working?
Yes. Yeah.
That's a fantastic question, and one that we have given a lot of thought to. So in general, the assays that are available in our clinical labs are not ideal, and the biggest problem is that they actually lack the sensitivity, for the most part, to detect protection from vaccine for varicella versus protection from a wild-type varicella infection. So really it's the sensitivity that we are lacking, but we don't have broad access to more sensitive assays. So as part of this study that we did have samples sent to the National Microbiology Lab for that testing, for the more sensitive testing. We will compare those assays with the clinical results because the patients in our study had both of those. However, when we are looking at patients that actually did have a documented response with the clinical assays, converting to a positive varicella IgG on that clinical assay, I think that is certainly reassuring because generally what we worry about is actually missing it. So I wouldn't say that a patient that had a negative varicella IgG on our clinical assays was definitely not protected, right? But if they do have a positive IgG, then that does give us some reassurance that they do have some protection.
Great, thank you. Michelle, another question, please.
Thank you. And this one kind of combines two questions that we've had from the audience. So the question is, has there been, this is for Charlene, and has there been any thought of extending the program later into life, for example, for older adults or other communities, Indigenous communities or refugees or newcomers?
Is this on? Well, like I said, it was already extended because initially it was meant just for up to the age of 2, and then because the participants didn't want to stop with their home visiting, that was when the Get Ready for Preschool program was created for the years of 2 to 4, and that's where the gap in most Indigenous communities are. Like normally you would see we're lucky to see a prenatal. Sometimes they'll only come to the health center to get their prenatal class only to get as an incentive of a car seat. And then you won't see them until after birth. And then we have a program where we see a postnatal twice, so the day after discharge and then about a week later just to check to see how breastfeeding's going and how the weight gain's going. And then you're lucky to see that baby at the 2-month visit for immunization. And then we might not see them until school age. So we were filling that gap where we weren't having any services for sometimes 3 years, 4 years even. And so right now we're just concentrating on that. And we did have people like in downtown Toronto that weren't of Indigenous heritage come to the Get Ready for Preschool or Understanding the Early Years course that we delivered over there. So hopefully they can adapt some of the strategies into other programs as well.
Thank you. We have time for a few more questions. Michelle?
So this question may have been touched upon already in some forms, but this one is for Dr. Burton. This question got upvoted 7 times, so I'll ask it. Have there been similar research going on? And this was in relation to when you were talking about the varicella vaccine. And the question was, have there been similar research going on for the MMR vaccine, especially with the increase in cases recently?
Yeah, absolutely. there has been a lot of research, very similar research, actually sometimes done by the same groups, that looked at varicella vaccine in their population and then looked at MMR vaccine. And really, it's very supportive that giving that vaccine using very similar kind of criteria is also safe in these populations, and there's good immunogenicity. So certainly, I think that in this situation where we had more circulation of measles and there was more risk of actually acquiring it, but that would certainly be something that we could consider looking at doing, especially in children that have already shown that they have tolerated varicella vaccine. So in that case example that I gave, if I can do immune investigations and I can see what numbers look like on paper, and that gives me an idea of what somebody's immune system looks like and what it's doing. But if they can actually show me that they can tolerate the live varicella vaccine, they can develop a response to it and not have an adverse event, that's a proof of concept that the whole very complicated immune system is working together well enough that it dealt well with a live vaccine. And so I would feel more comfortable giving the MMR vaccine to a solid organ transplant recipient that had already tolerated and had good response to the varicella vaccine.
Great, thank you. We still have some time, Michelle, so are there any more questions?
Yes, there's lots. So this one's for Charlene. The question is, how are the home visitors prepared to deliver the program, and are the home visitors nurses or outreach workers?
I thought I talked about it, but obviously I didn't. So when they are hired, another important point that I didn't make was 10 out of the 28 visitors currently were once participants of the program. So they saw the benefit that they had, and they wanted to deliver the same kind of support to the greater community. And once hired on, they take a 45-hour Understanding the Early Years course, which is similar to a early childhood development course that anybody in the mainstream might take. So they all have an early childhood background. Most come into work with already that existing early childhood program that they can get anywhere, and then it's enhanced by the program that we created to help prepare them for the work that they do.
Great, thank you. Well, we do have time for, I think, one more question, Michelle, if there's one available.
Sure, and this is for Dr. Burton. Do special immunization clinics support clinical management of adverse events following immunizations, or only focus on if a patient with an AFI should receive subsequent vaccinations?
Sorry, can you repeat the first part of that question?
Yes. Do special immunization clinics support clinical management of adverse events following immunizations, or only focus on if a patient with an AFI should receive subsequent vaccinations?
Right. That's an excellent question. And in general, the special immunization clinics are seeing patients often not like right at the time where there is an adverse event following immunization. Those generally go through to public health first, right? And they're the first point of contact for the AFI. And then the special immunization clinic is often involved after that when public health refers children or adults that have had challenging AFIs after immunization to our clinic. So not as commonly involved in kind of the acute management of things, because that is, at least in Alberta, a public health focus.
Okay, well, thank you very much. We are at time for this session. I just want to extend once more my extreme gratitude for your presentations today and hearing from your experiences of working with individuals, families, and communities in the promotion of immunizations within their own settings and their own context. So just ask for one more round of applause for both Dr. Catherine Burton and Charlene Rattlesnake. Okay, so we'll move on to our next round of poster presentations. So I'll ask our two presenters to come up to the stage, please. Okay, as with this morning, each presenter is going to do a brief presentation of their poster that is also in the hallway across from, and I'm going to get the room number wrong again, is it C240? Sorry, 420? Okay, sorry, got the numbers backwards. So I'll start with Genevieve White.
Right, good afternoon, everyone. Today, I'm excited to share some insights into recent polio surveillance efforts undertaken here in BC. Polio, as most of you know, is a highly infectious, vaccine-preventable disease that's primarily transmitted via the fecal-oral route, with the virus capable of being shed in the stool for up to 6 weeks after exposure. So there are two main types of polio viruses, wild and vaccine-derived, with the latter emerging when the weakened virus present in the oral polio vaccine mutates into a pathogenic strain, particularly in areas with low vaccination coverage. So while Canada exclusively uses the inactivated polio vaccine, the oral vaccine is still utilized in many parts of the world. And in July 2023, an outbreak of circulating vaccine-derived polio virus was reported in the Dadaab refugee complex in Kenya. So thank you for changing that slide for me. Between August of last year and February of this year, 43 refugees from Dadaab arrived in BC, many of whom may be unvaccinated or undervaccinated and susceptible to polio infection. So our project aimed to assess these arrivals for potential poliovirus exposure and symptoms, and to identify poliovirus infections, as well as to determine their immunization status and conduct public health follow-up. So this was achieved by completing standardized questionnaires to collect information on symptoms and potential exposures, such as recent contact with a case. Based on the responses, arrivals were then classified as either high or moderate risk and provided with corresponding public health measures based on their categorization. We also conducted provincial-level analysis and shared data with the Public Health Agency of Canada for centralized national analysis, as refugees were also destined for other provinces and territories. Now, given the asymptomatic nature of most polio infections, it's about 75%, the lab testing was a critical component of this research. So stool samples were also collected for each arrival and submitted to the National Microbiology Lab to screen for carriage of polioviruses. Okay, these are not the slides that I submitted, so this might sound a little bit off, but thanks to the dedication of the regional health authorities here in BC, we achieved a follow-up rate of 100%, so 43 out of 43 arrivals. You can't see it in the figure on the top right, but only a small proportion of arrivals, just 6%, had been vaccinated with the oral polio vaccine in the 6 weeks prior to arrival. And all 43 arrivals were classified as moderate risk based on the questions about symptoms and potential exposures to poliovirus. So I'm trying to see. This part is incorrect because they're the wrong slides, but we originally only had lab results for 33 arrivals. We just got the remaining 10 this past week because 10 of the arrivals just arrived in BC last month. And I'm pleased to share that 100% of arrivals tested negative for poliovirus. So I'll speak about some different conclusions and implications than what's up here. So based on the results that I just talked about, not what you saw on the slide, none of the arrivals exhibited symptoms compatible with clinical polio illness, and there was no evidence of any poliovirus shedding that would have potentially indicated asymptomatic transmission of polio. So although wild poliovirus has been eliminated from Canada, there is an ongoing risk of importation from areas with circulation of wild or vaccine-derived polioviruses, and this underscores the critical importance of maintaining high polio immunization coverage here in BC as well as the rest of Canada. So thank you, and please feel free to stop on my poster.
Thank you, Genevieve, and thank you for your patience with the technology. The next presenter is Dr. Zhuan Zhao.
Thank you, Laurie. Hello, everybody. It's my pleasure to be sharing the results from the Island Health QI project on grade 1 and 2 school-based immunization clinics aimed to improve vaccine access and coverage. While I'm up here presenting, this is really the combined work of myself and the Island Health staff, including Desiree Ord, Amber Thomas, Patricia Fothergill, Dr. Michael Banusik, and the staff at the Public Health Unit. So some of them are in the audience today. And this. We have no conflicts of interest to disclose. And just for some background information, at Island Health, we were seeing persistent 7-year-old vaccination coverage below 70%. And to address this, we implemented the school-based clinics for grades 1 and 2 with the intention to improve coverage to the Island Health target of 73% and simultaneously improve access to vaccines. Schools were eligible if vaccine coverage was less than 73% in either grades 1 or 2, and health units then identified and implemented vaccine clinics at schools in which clinics were likely to have a larger impact. And this took place near the end of the school year from May to June 2023. In terms of the data, we pulled vaccine coverage data from before and after these clinics on Panorama, and qualitative feedback was collected from health unit staff and analyzed using thematic analysis. As you can see at the bottom here, clinics were implemented at 13% of all schools in Island Health. This also represented 35% of all eligible schools, in other words, ones with coverage less than 73%. And in total, 236 students, or 29% of those who were eligible, became up-to-date post-clinics. And the key results that you can see there were that across all participating schools, there was a 9 percentage point increase in vaccine coverage from 67% to 76% up-to-date, bringing it to the target of 73%. And at the health unit level, the percentage point increase ranged from 2 to 13% at participating schools. And in coverage across all of the schools, participating or non-participating in these clinics, that increased by up to 5 percentage points at the health unit level, and across all of Island Health, this increased by 1 percentage point from 72 to 73% before and after these clinics. And here we can just see a graphical representation of the change in coverage pre and post clinics, with the participating schools on the left and the non-participating schools on the right. And each bar represents a health unit. And as you expect, we see a lot more of an increase in coverage at those schools with the clinics, and also demonstrates the impact that these school-based clinics had on improving vaccine coverage. And you can also see there is some variation between health units on how effective these were. This is just a little sample of the qualitative input we received from health unit staff, but this is invaluable for consideration in future school entry campaigns. Portions of the feedback that we received, including recommending having schools earlier in the school year, having an online consent system, better incorporation with other vaccination activities like our phone reminder system, and ensuring that there's adequate staffing above the needs of a grade 6 to 9 vaccine clinic, and also clear guidance for immunizing when the guardian isn't present. So So just to summarize, the grade 1 and 2 school-based immunization clinics were effective in increasing vaccine coverage, even with a small proportion of participating schools. And also, these results highlight how important multifaceted approaches are to increasing vaccine access and coverage. And our recommendations for future iterations of the school-based school entry vaccine clinics is to coordinate these with other types of outreach and pre-existing vaccine campaigns like the grade 6 to 9 campaigns, and to consider these clinics for younger grades such as kindergarten for earlier protection and boosting as kids go into school, and to adequately resource and support the health unit staff to be able to offer these clinics. That's everything.
Great. Thank you very much. I just want to say thank you again to all of the poster presenters that have taken the time to speak with us today, and to encourage those of you who have not had a chance to do so, so please visit the poster area, which is outside just across from room 420. And as that concludes this session of the afternoon portion, and we will move into a 15-minute break with our last session starting at 2:30. So I'll ask that everybody be back in here for a prompt start at 2:30 this afternoon. Thank you.